Every small step you take is carrying you exactly where you're determined to go. I'm walking with you.
Your roommate has been diagnosed with tuberculosis. You are identified as a close contact, but you have no symptoms. The first test performed is IgRA. So, what does IgRA actually test? Exactly. It determines whether you have ever been infected with Mycobacterium tuberculosis. Now, what is another test used for the same purpose? The tuberculin skin test. In this video, we'll break down what the TST is actually measuring and how to interpret it. A red arm doesn't mean tuberculosis. TST is a screening test used to determine whether a person has ever been infected with Mycobacterium tuberculosis. It does not diagnose active tuberculosis. So, how is the tuberculin skin test performed? Point 1, 0.1 milliliters of PPD is injected intradermally into the forearm. Point 2, the injection site is examined 48 to 72 hours later. What you measure is induration, not erythema. The tuberculin skin test is a type 4, delayed type hypersensitivity reaction. After prior exposure to tuberculosis, the immune system forms TB-specific CD4-Th1 memory T cells. When these cells are re-exposed to TB antigens, specifically PPD, the memory T cells become activated. They release interferon gamma, which recruits macrophages to the site. This localized immune response produces firm induration. So, a positive TST reflects cell-mediated immunity to tuberculosis antigens. Let's quickly review hypersensitivity reactions, types 1 through 4. Type 1 is immediate hypersensitivity. It is mediated by Ig and mast cells, and it happens quickly. Common examples include allergies, asthma, and anaphylaxis. Type 2 is antibody-mediated hypersensitivity. IgG or IgM antibodies target cells directly, leading to cell damage. A classic example is hemolytic anemia.
Type 3 is immune complex-mediated hypersensitivity.
Antigen, antibody complexes form and deposit in tissues, causing inflammation. Systemic lupus erythematosus is a typical example. Type 4 is delayed type hypersensitivity. It is mediated by T cells, not antibodies, and takes 48 to 72 hours to develop. Examples include the tuberculin skin test and contact dermatitis. So remember, type 1, Ig and immediate. Type 2, antibodies attack cells. Type 3, immune complexes deposit. Type 4, T cells and delayed. Now let's talk about interpretation. This is high yield. The cutoff for a positive TST depends on the patient's risk category. An induration of 5 mm or more is considered positive in patients with HIV, organ transplant recipients, or those on prolonged steroid therapy. 10 mm or more is positive in healthcare workers, recent immigrants from high prevalence areas, and close contacts of TB patients. And 15 mm or more is considered positive in individuals with no known risk factors. So, what does a positive TST actually mean? It tells us that the patient has been infected with tuberculosis in the past, and that latent TB infection is possible. However, a positive TST does not tell us whether the disease is latent or active. And it also cannot distinguish true TB infection from the effects of prior BCG vaccination. Now let's talk about the limitations. This is an NBME favorite. False positive results can occur in patients with prior BCG vaccination or exposure to non-tuberculous mycobacteria. False negative results may be seen in immunosuppressed patients or very early after TB infection. The test also requires 2 visits, one for injection and one for interpretation. Because of these limitations, in the United States, IgRA is preferred in patients who have received BCG vaccination. TST detects TB-specific memory T cell responses via a type 4 hypersensitivity reaction. It indicates TB exposure, not active disease. Thanks for watching until the end. In the next video, I'll walk you through the actual diagnostic algorithm for tuberculosis.
For quick, powerful reviews, this is the only channel. Don't forget to subscribe.